Okay. Now we can proceed to the next speaker. The next speaker is also one of the thoracic anesthetists that is a good friend in the Thoracic Subcommittee of the EACTAIC, Vegh from Debrecen in Hungary. And Tamás is going to talk about neuromuscular monitoring and muscle relaxants. Please, Tamás.
Thank you, Mert. Good evening to everyone. Yeah, it's okay. Okay, so everybody knows that the successful surgery has two major components: the happy anesthesiologist and the happy surgeon. Anesthesiologist is happy when the intubation, the airway securing, is a smooth process. And the study, it's a large, huge study with more than 100,000 patients involved. They compared the intubation with and without muscle relaxant. And it's a general anesthesia study. The patient were intubated with a single lumen tube. And in this case, with a muscle relaxant, the rate of the poor intubation condition was over 60% versus 4% using a muscle relaxant. So they conclude that muscle relaxant-free intubation is an independent risk factor for a difficult intubation. In thoracic anesthesia, as Matt will show you, we use double lumen tubes. Double lumen tubes that are bulky tubes, and the intubation with these double lumen tubes for one-on ventilation requires a more relaxed patient compared with the conventional single lumen tubes. As I said, a surgeon is happy, life is happy. We can use muscle relaxant to improve the surgical condition. It may seem unnecessary because the rib cage is a rigid cavity, so the rib cage provides thoracic support, and one ventilation usually provides a satisfactory surgical field. However, on the other hand, the thoracoscopic surgeries involve areas adjacent to the major blood vessels and can trigger intraoperative body movement, cause and diaphragm movement. So if we use muscle relaxant, we can inhibit the response to the coronary stimulation and prevent bucking and coughing during the surgical procedure, despite the total ablation of the albus or pollicis muscle train of 4. Sometimes we have not to use, or we cannot use muscle relaxant. We have some contraindication. One of them is myasthenia gravis. Myasthenic patients are usually very, very sensitive to all non-depolarizing muscle relaxants. So the use of muscle relaxants are unnecessary. The use of muscle relaxant is still controversial in myasthenic patients, but we have to note that rocuronium could be useful after the induction if Sagamadex as a selective antagonist is available. The use of remifentanil can reduce the response to airway manipulation out of intubation with muscle relaxant. In our practice, we administer some fentanyl to the patient, we anesthetize IV propofol, and when the patient is unconscious, we turn on the vapor and we ventilate with the mask bag ventilation with the sevoflurane, and it provides sufficient relaxation for the intubation with a double lumen tube also. The second issue that can be a contraindication for the use of neuromuscular blocking agent is the anterior mediastinal muscles. If we need a muscle relaxant to use, a small dose of short-acting muscle relaxants, for example, succinylcholine, can be used and mechanical ventilation attempted. What we can use for muscle relaxant in thoracic surgery: use of a steroid neuromuscular blocking agent like rocuronium, or less commonly the cisatracurium, and atracurium is recommended. as I mentioned, the intubation with a WMN tube could be very difficult, and sometimes we need a very deep relaxation. Rocuronium in high dose, about 1 milligram per kilogram, or succinylcholine 1.5 milligram per kilogram can be used interchangeably for the rapid tracheal intubation, because they provide adequate intubated condition within in 1 minute to 90 seconds. Hence, if succinylcholine is considered undesirable or contraindicated, you can use a high dose of rocuronium for the intubation. Choosing the neuromuscular blocking agent depends on the patient comorbidities, duration of the surgery, and availability of the antagonist, and the experience of the anesthesiologist. You can see in the table, all the drugs has some side effects. Cisatracurium has the least side effects. The cisatracurium doesn't stimulate the autonomic ganglia, has no effect on the cardiac muscarinic receptors, and has no histamine release. And cisatracurium is eliminated with the Hoffman elimination. There's no need for the elimination. There's no need for the kidneys, for the liver. Rocuronium has no effect on the autonomic ganglia, blocks weakly the cardiac muscarinic receptors, and has no histamine releasing effect. Succinylcholine stimulates the autonomic ganglia, stimulates the cardiac muscarinic receptor, and has a slight histamine releasing effect. Okay, we know what can we use, but how can we use it? How deep of a neuromuscular blockade is optimal for thoracic surgery? The deep neuromuscular blockade can increase the surgeon's satisfaction, reduce the risk of diaphragmatic movements and coughing during the surgery, and improve the lung mechanics. In contrast, we have to decide how we administer the muscle relaxant, in bolus or in continuous infusion. Continuous infusion of neuromuscular blocking drugs may not improve the surgical condition, with no significant benefits of other outcomes, including the intraoperative surgical event, pain scores, and duration of the surgery. However, the deep neuromuscular blockade may increase the incidence of the residual paralysis and the postoperative pulmonary complication. I will explain in the next slides. However, the increased risk of postoperative pulmonary complication due to the residual neuromuscular blockade effects remain a relevant issue. So the usefulness of intraoperative deep or moderate neuromuscular blockade is still controversial.